Okay, thanks, Anna. And just get ourselves set up. Good. Okay, so thank you so much for that introduction, Anna, and thank you to Trauma Care for the invitation to talk today. And I'm going to be talking about the trauma laparotomy, not just for non-trauma surgeons, but for non-surgeons in general. As Anna said, my name's Nick Newton. I'm a consultant trauma and emergency surgeon at the Queen Elizabeth Hospital in Birmingham. I'm also a full-time serving medical officer in the Royal Navy, and I've got a deployed experience and civilian training experience from a number of different locations. This is not a talk that's going to have lots of evidence and lots of references and lots of papers. This is a talk that hopefully is going to demystify things a little bit and perhaps put into perspective why it is that surgeons can have, shall we say, a certain reputation for how they behave and how they react. And I'm not going to try and be an apologist for rude surgeons in any way, but perhaps just open people's eyes to the fact that whilst we are obviously trauma gods and can do no wrong, sometimes it's not quite as simple as we make it out to be. So for those of you that have done ATLS or ATNC or any of those sort of courses, you'll be familiar with this sort of précis, an at-mist type scenario. So we've got a 26-year-old, they've crashed their motorcycle and they're unwell. Fill in some numbers how you please. Their airway's fine, they're bleeding into their chest, they're bleeding into their pelvis, they're bleeding into their abdomen, and you know from your primary survey interventions that you can stick in a chest drain, which will sort their B hemothorax problem out. You can put a binder on them, which will sort their pelvis bleeding out. They haven't got any long bone injury, they haven't got any external blood on the floor, and so they've got abdominal bleeding, and you turn around to your ATLS faculty examiner and say, I want a surgeon, they need an XLAP. And if your examiners are anything like the way that I do my ATLS courses, I turn around and say, great, the surgeons will be along in about 5 minutes, carry on with your ATLS moulage. And that's really it. And so for a lot of people, the famous exploratory laparotomy, trauma surgery laparotomy, is that it's just a mythical thing that fixes bleeding in the pelvis, and oh, but that were true. So for me, certainly, and I think most people that have ever done a trauma laparotomy, there is a slight mythical element to it. It's the ATLS, as we've just talked about. And then on TV, there's a lot of blood. There's a lot of shouting. There's a lot of running around hospitals shouting stat a lot. There's lots of adrenaline, some of it even in the patient, hopefully not given to the patients, but potentially the patients made quite a lot of it or released quite a lot of it themselves. There's usually a fairly cool soundtrack. There's usually a shouty surgeon looking cool, possibly with a scrub hat with a cartoon on it. And we're just going to try and unpick some of that and just perhaps put some of that mystique into perspective. So what is a trauma laparotomy? Now, I'm perhaps what we're going to talk about on this slide is perhaps not what you're expecting and not what some of my surgical colleagues might expect. So I'm going to describe all of these types of surgery as trauma laparotomies. So for me, there's the trauma laparotomy in the next few minutes. That's the TV, that's the shouty surgeon, that's the cool headlight, that's the cool soundtrack. That's the damage control procedure, which we'll talk about in more detail. That's the all guns blazing, get your trauma shears out, don't worry about putting on scrubs, don't worry about prepping the patient. It's what I call the awake laparotomy, okay? That's someone who's going to bleed to death. But actually, if you've got a bowel injury from a penetrating injury, or if you've got some ischemic bowel from a car crash where you've torn the mesenteric vessels, you can wait a few hours, but you're still having a laparotomy to treat a traumatic injury. If you've got a penetrating injury to the diaphragm, it might very well be that you can have that managed laparoscopically in the next few days. When you've got better from your other injuries, maybe when a laparoscopically capable surgeon comes on call. And then finally, we might talk about a trauma laparotomy for something like a hernia repair or a Hartmann's reversal or an abdominal wall reconstruction. And that for me is still a trauma laparotomy, but that might happen years after the event. And my personal record on, please put in the comments if you've got experience of this. But my personal record is 20 years from a gunshot wound to the abdomen, which left a diaphragm injury, and 20 years later, the patient came in with a symptomatic diaphragmatic hernia, which we repaired. And I think it's important to appreciate that all of those are trauma laparotomies. Now, for the purposes of this talk, broadly speaking, we're talking about the trauma laparotomy in the next few minutes. But just remember, that's not the only thing that we're talking about. So, unfortunately, it doesn't quite show that the right-hand side of my screen is slightly hidden, but this is just a pictorial, diagrammatic representation of what I was talking about. And just highlighting that at the damage control surgery end, at the surgery within minutes end, this is maximally invasive. Some surgeons talk about single incision surgery, but it's not single incision laparoscopic surgery. It's a big cut all the way down the middle of the tummy, no holds barred. By the time you get down to a laparotomy for bowel perforation, you might even be contemplating doing that laparoscopically or through a very small incision in a calm, cool, daytime, elective style setting. And right at the end for an elective repair of an identified injury, or shall we perhaps a laparoscopic reversal of a Hartmann's or a repair of an incisional hernia, you might be going fully minimally invasive, fully laparoscopically. They are all types of trauma surgery in my book, but not quite the cool, shouty soundtrack of the damage control procedure. So some important concepts to think about, even for experienced trauma surgeons in busy centres. This is not a daily occurrence, and we're lucky. And these comments do apply to the UK. I know there are parts of the world where this is not true. But generally speaking, for most UK surgeons, these are unusual operations. No matter how experienced you are and how good you are, for a number of reasons, it's quite stressful, not least of which the fact that your patient is doing their best to bleed to death. But this usually happens at 3 o'clock in the morning. You are not going to be with your familiar, lovely elective team that you know really, really well from your favorite theatre and your favorite anaesthetist. And this last point on this stage, on this page, I think is really important. Certainly in my hospital, the consultant surgeon is usually not present when the patient arrives. The way that we have our setup is the patient arrives, they're met by a trauma team, they have their primary survey, they go for their CT scan. The CT result comes back and then someone says, this patient needs a general surgeon or it needs an operation, phone the general surgeons. And if the patient is sick, that process might happen quite quickly. So as the consultant, I will walk into the trauma bay and I will be met by a group of people who are already hyped up in the situation. They are completely swept up. They know what the situation is. They know what's going on. They have a shared mental model of what they want to happen. And they're standing looking at you saying, right, we know what's going on. Why don't you? You need to know what's going on. Get on with it. And actually, it does take a few minutes to assimilate information, establish what's going on, make your own mind up about what's going on. And that's the time when the surgeons can appear difficult. They can appear aloof. They can not communicate well. They can seem like they're skipping important steps. And they're not necessarily doing that. They might just be catching themselves up and getting themselves into the game. Now, we often say that trauma surgery is not the time for an MDT. It's not the time for a traditional cancer or complex care multidisciplinary team meeting. But I push back against that, and most trauma care professionals now do and say, yes, we do have MDTs, but we have them quickly. We do have MDTs, but sometimes we will have them in advance of the patient arriving, not knowing what the patient is, but saying, look, we will always do a primary survey. We will always aim to get a CT scan. We will always get access, take blood, give blood if we're worried. So a lot of those decisions about care that the multidisciplinary team makes have already been decided before the patient arrives. But the surgeon might be coming to that party late and you've got to play catch up. So there's lots of decisions. And one of the big decisions for me is there a shared mental model? Does everybody in the trauma bay have a shared mental model of what's going to happen to that patient? Because if they do, stress is going to leave. The process is going to be easier, not easy, but easier. If there's not a shared mental model, for instance, if your trauma team leader says the patient needs to go to CT, and the general surgeon or the trauma surgeon is standing there saying, you've got to be kidding, this patient's bleeding to death, they need to go to theatre, that can be challenging. Or people are saying, right, well, do we go to theatre or do we go to interventional radiology? And perhaps no one knows. Perhaps there is no clear right answer. And the surgeon has to make a decision, and that may be a decision that they're not comfortable making. So again, they come across as perhaps being a little bit short. People don't do well when we're under stress. Okay, you can learn, you can practice, but we can always be broken. What's the hospital process? Is the surgeon fighting against a process or with a process? Is it clear what the patient needs? I mentioned that sometimes interventional radiology is right, sometimes open theatre, open surgery is right, sometimes there is no right answer. And then finally, are you actually a laparoscopic bariatric surgeon? Are you a specialist cancer surgeon? Are you a locum who does hernias and gallbladders and hasn't seen trauma for 20 years? Okay, are you the right person in the right room? GI surgeons, many of us, have not done vascular surgery for a long time. Now, I am a trauma surgeon. I do not market myself as a vascular surgeon, but my military practice means that I need to maintain some vascular skills, and I'm happy doing that. But some of my colleagues, and certainly people I have come across in my training, are much less happy with that situation. So is the surgeon the right person? If they're not, they will get stressed. So as we come on to more of the nitty-gritty, the nuts and bolts, the technical aspects of a trauma laparotomy, we're going to be more thinking about the shouty, cool soundtrack type work. And the point of that type of laparotomy, of that approach, is to remove some of the decision-making, to remove some of the uncertainty, and to let you get away, or not get away with it, that's not quite the right way, is to allow you to do the same operation every single time for every single patient in a structured fashion, so that you get yourself from a place of danger and uncertainty, a bleeding, unstable patient, to a place of safety, so a patient where the bleeding is controlled, the contamination is controlled. And at that stage, you can start making some more decisions, and you can decide, can you fix the problem and do a single stage procedure? Do you need to start thinking about damage control and stage procedures? And we'll talk about that in a second. So a trauma laparotomy follows a set sequence of actions to minimize delays, to control life-threatening bleeding, and manage contamination. And we don't get caught up in the niceties. If we're doing it properly, it's going to be messy, it's going to be carnage, it's going to not look pretty, but at the end, you'll have a live patient. And ultimately, that's what we're looking for. And so for the rest of this conversation, the rest of this webinar, we're going to differentiate a laparotomy for trauma, which is those hernia repairs, those bowel perforations that can be done in daylight hours, from a trauma laparotomy, which is the smash and grab cool soundtrack. I'm just going to move my my screen so we can, my face, sorry, so that you can read that. So this quote from Pablo Picasso is really important for me, okay? Just because we're doing a smash and grab, cool soundtrack, shouty laparotomy does not mean that we can skip all of the essentials of safe perioperative practice, okay? This is not an excuse to be a cowboy. This is not an excuse. This is facilitating you in doing what is best for the patient. So we consent. Now, I will freely admit, and this is a little bit controversial, that I'll talk about my approach to consent in a minute, but we do consent patients. The principles are identical. If a patient has capacity, then they can consent. Now, I have an issue with some people who will literally get a patient to sign, and they've had 2 or 3 litres of blood loss, they've got blood going, they've got a partial amputation of a leg, they're going for theatre whether they want it or not, they've had their 20 milligrams of morphine, they're getting ready to, they've got their mask on their face as they pre-oxygenate, ready to be RSI'd, and someone says, well, just sign on the dotted line and you'll be fine. Now, that for me is not consent. Okay? I think that, and many people do agree with me, I'm not totally out on a limb here, but I do acknowledge that my approach is quite paternalistic. But if you've had drugs that interfere with your cognition, if you have significant injuries, if you've had blood loss, all of those will impact your ability to your capacity and will impact your ability to give consent. And so I am quite on one extreme of doing a best interests paperwork. That doesn't mean that you don't explain the case to the patient, explain your thinking and explain what you want to do for them. But I do think that just getting someone to scribble a little wiggly line on a form is not the same as getting consent, but it has to be thought about. Sometimes people will have seen or heard about operations where we are not wearing scrubs, and I have done a laparotomy wearing shorts and t-shirt. Not often. We try to do things properly. We always wear full PPE. I always wear glasses and I'll have a hat, and nowadays masks are de rigueur in the era of COVID, but I would always wear a mask personally, and everyone should, but the eye protection is really important. I always double glove for all my operations, but if you're doing trauma, most people will recommend double gloving. I'll show you a picture on the next slide of how the patient is prepared, but both arms are out so that the anaesthetist can get access. We prep all the way from nipples to knees, including the groins, especially if we don't know exactly what we're going on. If the patient hasn't had a CT scan yet, we've got to be prepared to go into the chest, whether that's to get proximal control for bleeding in the abdomen or whether that's to actually deal with a chest injury. It's nice to have an NG tube and a catheter, so a nasogastric tube and a catheter, but don't let that delay your operation in a bleeding patient. There is always time to do that later. Trauma patients get cold, we know this, so we want to try and keep them as warm as possible. PPE we've mentioned, and I'm really, really hot from personal experience, having experienced what goes wrong when patients get the wrong operation. Luckily, not my responsibility, but my personal involvement. The WHO briefing is really important, and it doesn't have to be a long, drawn-out process. I've put 20 to 30 seconds on this slide, but frankly, 10 to 15 seconds of a quick situation. Have we got blood? Are the anaesthetists happy? Have they had the necessary drugs? Scrub team, are you happy? Go. That's literally all you need. In my organisation at the Queen Elizabeth Hospital, part of the University Hospitals Birmingham, we have a dedicated WHO surgical checklist for our Code Red cases. So our Code Red is our highest level of triage activation, of trauma team activation for those patients who we are worried are bleeding. And in addition to extra personnel being activated for our Code Red, that also gives us quick access to blood and blood products. So we combine the sign in and the timeouts. There's an intraoperative brief, which we'll talk about in a second, and then there's a sign out. But if you look at the combined sign in and time out, it's about blood, it's about tranexamic acid, it's about the basics that will keep the patient alive. Very quick. So this is the sort of archetypal perfect position, but I'm sure you can appreciate that if you've got this much skin exposed, you're going to get cold. You're going to get cold whether you're traumatically injured or not. So you've got to think, can I keep the patient warm at the same time? Oftentimes in these high energy or high adrenaline, high emotion laparotomies, the anesthetic and the surgery will be simultaneous activities. So there'll be multiple interventions, and there may be other injuries. There may be limb injuries. They might have a pelvic binder on that's getting in the way. They might have a chest injury. Now, I actually have this on a t-shirt. I tell everybody that I work for about this phrase. I have decided that it probably is attributable to the Navy SEALs. What I haven't quite decided is whether it's from the Navy SEALs, the military unit, or the Navy SEALs, the movie, probably doesn't matter for the purposes that I'm using it for. But slow is smooth and smooth is fast. What does that mean? It means if we rush, we will make mistakes, and that will cause problems that need to be fixed that slow us down. I will give you a good personal example, because I'm not going to give bad stories about other people, but I was doing a trauma laparotomy about 3 weeks ago for someone who had stabbed himself in the abdomen, who was critically unwell with an unrecordable blood pressure, and we needed to get in quickly. So I did a big midline laparotomy. I didn't appreciate that a small loop of small bowel had herniated through the stab wound, and he got an iatrogenic injury from my blade. Now, that was easy to fix. It was quickly recognized. It didn't cause him any problems. But that was me not quite following my own mantra of slow is smooth, smooth is fast. And for those of you outside of theatre, you all know this is true. When we're moving patients from an ambulance trolley to an ED trolley, when we're moving patients from a trolley to a CT table, it's all about, have you got the lines? Have you got the tube? Have you got control of everything that we could pull out? Because God knows if we're not careful, okay, every chest drain, every central line, every ET tube is going to be pulled out if we can possibly manage it. So slow is smooth and smooth is fast. So what does the operation actually entail? It is a midline laparotomy. So that is a big cut from the sisyphus all the way down to the symphysis pubis, hopefully not causing too much damage in the process. The patient will tell you how quickly you have to do this, but we'll see a video example in a second of perhaps how not to do it. And it is a recognized video of how not to do it. It's not just me being mean. But don't worry about bleeding from the wound. Patients don't bleed to death from their midline laparotomy. They bleed to death from the stab wound to their IVC or to their common iliac vein. Try to avoid injury to the bowel, primum nocere. It's part of the Hippocratic Oath, although I am clearly not the person to be telling you about that. And then the approach that I take is I don't stop and brief the team, but as I go into the abdomen, I just speak out. You can probably guess that I have quite my voice can carry when I want it to. Should we just leave it at that? And I'll tell people what I found. Okay, so it'll be into the abdomen and it'll be lots of blood or no blood or a little bit of blood and lots of bowel contents. Just something quick so people understand what we're dealing with. So the first thing that I'm going to do is scoop out as much of the blood as possible. I want to put a pack or a big swab or a big bit of gauze. I want to put some pressure on whatever is bleeding. I'm not going to go looking for it. I'm going to put pressure everywhere. But there's no way that I can put direct pressure on a bleeding vessel if there's 1.5 liters of blood in the way. So I'm going to scoop that blood out. I am not going to be my scrub nurse's best friend at the end of this, because that big swab covered in blood might very well end up all over his or her nice clean drapes. But if it's not going on the drapes because there's no space, it's going on the floor behind me. Okay. And the next one's going on the floor behind me. And that's going to be part of the count. It's going to make a mess. We'll just have to deal with it. I'm quite happy to mop the theatre afterwards. I'm not precious about that. So long as the patient is alive, I'm happy to do any jobs that are required. Eviscerate. Again, we're not going to be able to put solid pressure onto bleeding vessels and bleeding organs and bleeding points if there's nice bits of squidgy soft bowel in the way. So get that bowel out of the way, move it out of the way, and then pack. Pack, pack, pack. Large swabs or lap pads for, I think we've got at least one American viewer, or lap pads. And we typically pack all 4 quadrants, described as the left upper quadrant where the spleen is, the left lower quadrant where the sigmoid colon is, the right upper quadrant where the liver is, and the right lower quadrant where the cecum is. And then we shove some down into the pelvis as well for good measure. And I always have 20 large pads or large swabs, packs, whatever you want to call them, open at the beginning of the operation. And you don't have to be rude, and I try not to be rude, although some of my scrub team might disagree, but it's just a simple pack please in, pack please in, pack please in, and it's about that quick, and it's just get on with it. And the reason that sometimes surgeons will get a little bit short, the reason that we'll be a bit stressed, is because we're in a rhythm. we've got a plan, we're doing our job, and someone says, oh, I haven't got any swabs, or you hear the scrub nurse saying, oh, can we have some more swabs, please? No, have them all open, have them all ready to go at the beginning, please. And in a swept up system, in a major trauma center, hopefully, or in a system that is used to this sort of thing, all of that happens automatically. But if it's not, as surgeons, we have to appreciate that everybody else is doing something stressful and unusual. Okay, I know a lot of my emergency theatre team are not comfortable doing these big, scary laparotomies, but also the team have to appreciate that the surgeon in the middle of things with the patient might not be at their most comfortable. So when I've finished packing all 4 quadrants, when I feel that I've got a modicum of control, the equivalent of putting my finger on a bleeding vessel in the abdomen, or just putting direct pressure for the pre-hospital and the volunteers, people that are out and about dealing with things, that lifting the arm up, pressing on something, getting a t-shirt and pressing on some bleeding, okay, that's my equivalent of doing 4 quadrant packing. I'm going to stop, I'm going to brief the team. And the first thing I want to know is the anaesthetist happy? Have I got control of the bleeding? Because if I haven't, I've got to do something else. And there's other things that we can do which are outside the scope of this talk, but there is more we can do, but I need to know if I need to do it. I need to talk to the scrub team. Do they need time to open more kit? I have at one point, once or twice, I have done 4 quadrant packing without wearing sterile gloves and a gown, for instance. So at this stage, I get a tap on the back, tap on my shoulder. I turn around and my scrub nurse puts me in to my gown in a very, very American fancy style, and lets me put my gloves on, and then I can turn around and carry on operating. It may be that they need to open some more sets. It may be that at that stage, I've immediately recognized that this is totally beyond my abilities and I need someone else. It may be that we need another scrub nurse, because 2 scrub nurses in a big trauma laparotomy is not unreasonable. And it may be that the anaesthetist says, yeah, we're doing well, I think you've got control, but actually I need to give another couple of units of red cells, and I need to get another couple of units of FFP, and I need to give some platelets. So just hang fire for 5 minutes while we catch up, and then you can do some more stuff. But the only way we'll know that is if there is a 2-way conversation about that. So I've mentioned the concept of damage control surgery a couple of times now, and I'm just going to touch on what that is. That we could do a whole webinar on damage control surgery, but the fundamentals are that we're going to prioritize physiology over anatomy. So what does that mean? That means that we're not necessarily going to do beautiful bowel anastomosis. We're not going to join the bowel together. Similarly, we're not going to necessarily join blood vessels together. We might put a little plastic tube in to act as a shunt, and we might not close the abdomen, so we might leave the abdomen open. So the aim is to prioritize physiology, to keep your operation as short as possible, to limit the patient getting cold, to limit blood loss, which is going to contribute towards their coagulopathy, which is going to contribute towards their acidosis, which is all going to work together for the bloody lethal triad, which we know carries a significant mortality. Control bleeding, control contamination, live to fight another day. That's the patient. Clearly, as the surgeon, you're probably going to survive to fight another day, but you want to walk out of your operation feeling good about things. And then we leave the abdomen open and we temporarily close it. I didn't give a conflict of interest statement at the beginning, but I'll say now that Abthera is the commercial product produced by KCI, and they have supported other teaching sessions that I've given. There are other ways of temporarily closing the abdomen. At the QE, we use Abthera. It's a really nice, easy to use product, but you can use that. There are other techniques described. There's some really great pictures on the internet of using towel clips. First of all, we don't have sharp towel clips anymore, so you can't do that, but that's very much for historical value. We do occasionally just close the skin, but there are very specific reasons for that. And you can make negative pressure dressings out of sterile drapes and large packs, but Abthera, it really should be you know, what we aim to use if your hospital has it. I'm going to show this video and talk over the top of it. This is taken from an American military course and is an example of how not to do it. Okay, the quality is not great. The background is that this is a trauma laparotomy performed by US military surgeons in Afghanistan. It's a few years old now, and you'll see a couple of the things that we've been talking about. So I'll press play and then I'll narrate over the top the bits that I think are important. And this is our first technical failure. Anna, if you could help out. It's just saying media not found.
No worries. What I'll quickly do is, because I've got this same PowerPoint in front of me. So I don't know if you want to just pre-explain the video. I know you've said that it was the American and sort of how not to do it, and I'll quickly wait for this to load and see what's happening on my end here.
Thanks. So what you're going to see is a trauma laparotomy, but you'll see the surgeons start off with a knife, which is very reasonable. You'll see that on the right-hand side of your screen, and I'll just try moving my picture down a bit so you can see there's a pair of hands coming in because someone's putting a chest drain in whilst the laparotomy is going on, and they're obviously not gowned and gloved. They're gloved but not gowned. And what you'll see is that the surgeon picks up the diathermy or the bovie. He's an American surgeon, so he calls it the bovie, and starts doing some diathermy to open the abdomen, exactly as we would for an elective surgery. And then he quickly realizes that there's lots and lots of blood, and so changes tack. And then you'll see them pack, but the packing is a little bit haphazard. They don't eviscerate, they don't get rid of the blood. And at one point, in a true example of wonderful multidisciplinary team trauma management, the anaesthetist joins in and starts handing packs in. And whilst I'm all in favour of team trauma activity, I prefer the anaesthetists to focus on the anaesthetic rather than helping me out with my surgery. So if Anna's ready.
Yep, so I'm just going to stop sharing your screen. I'm going to share mine, and everyone can watch the video from the presentation that I've got here. So I'm not going to make it large so everyone can see that, I believe. So hopefully you can all see this.
Good. So if we start at the beginning, you'll see using the knife, and he's got a nice instrument to hold the skin, and it's all beautiful. And then he's got the diathermy being handed, and he's got some suction from his third assistant. And this is all nice and slow and nice and slow. And any second now, they're going to realize that slow is possibly not the right thing. Ignoring everything I said about slow is smooth and smooth is fast, they need to get on with it because there is quite a lot of blood. So they get a nice big pair of scissors, which is a fairly standard technique, which is really nice. It's a really quick and safe way of getting in. And they haven't really scooped out the blood. They're just sort of packing, but the person putting the chest drain in is clearly getting very involved and is putting those little packs in just to make the scrub nurses count really challenging, because it's all about making the scrub nurse's life difficult. And we're just putting lots of these small packs in. But we don't really seem to be following any particular logic at the moment. They just seem to be going in. And all the small bowels still in there. So what we're doing is putting soft, squishy bits up against what we're trying to press on. So we've decided we've done the whole of the left side. There's clearly more blood coming out, so we're going to do some more. We haven't finished the laparotomy yet because we still need the scissors, so we haven't quite made the hole big enough yet. We're not sure what we're doing next, so we're going to get some more sort of medium-sized swabs and maybe a retractor right across the middle of the surgeon's field. And now the anaesthetist is helping out. Oh no, this is the scrub. There's the anaesthetist, because it's all about teamwork. And then we're pushing. And now we've got some nice big swabs, and we're going down into the right lower quadrant. And we seem to be sort of getting anywhere. That's getting somewhere. There's no more blood coming out. and that's all looking good. And that's probably as much as we need to show, Anna. So if we stop that there, and I'll go back to sharing my screen. So apologies for that technical failure. So 10 at 10. A number of colleagues, I mean, we talk about this concept. So this is a 10-second brief every 10 minutes or so. And the people that I look to, who are my mentors, the people that I've been trained by, actually say they don't do this. Clearly, you know, it's A, it's never 10 seconds, and B, it's never every 10 minutes. But I think the concept is quite important. It's nice that you've got a very short communication done at relatively regular intervals, so that the team know what's going on. Because if everything just goes silent, you don't know, is it going well? Is it going badly? So the first time to do a sort of 10-second brief is once you've gained control of the abdomen. And this is what we mentioned earlier. Is this a straightforward injury pattern? That's quite useful. So is this just a straightforward mesenteric injury that's going to need a bit of a bowel resection, but nothing to get too stressed about? Is this a complex vascular injury? Do you need help? And it doesn't necessarily need to be specialist help. I don't necessarily need a vascular surgeon. It might just be, I need another pair of hands. Luckily in Birmingham, where it's rare to be this busy, but I have on occasion had to have 3 sets of surgeons in doing, because we had 3 cases on the table simultaneously. And at that point, it doesn't matter how good you are, you can't be doing 2 operations at the same time. Do we need special equipment? I do not open energy devices. I do not open fancy elective retractors at the beginning because I don't think they're needed. But actually, if there's a complex injury that requires special space, or more space rather than special space, or if a fancy energy device is going to be useful, then this is the time to ask for it. And then you want to know, how is the patient? And I will give an example of why this is important now. So how is the patient, and does the anaesthetic scrub team need time to catch up? So I will give a really quick vignette about a patient. We had someone come in. It was a blunt RTC type injury. The patient had come in, they were unwell, they were hemodynamically compromised. They had bilateral chest drains out, blood came out, but not enough to worry, but a lot of blood came out. Took them to the operating theatre, did their laparotomy, they were bleeding, we fixed that problem, packed the abdomen. I'm very happy that we got control, and the anaesthetist told me they're still bleeding. So we played around with the chest tubes, realised they were still bleeding in the chest, opened their chest, packed their chest, and then waited for the cardiac and the thoracic surgeons to come. And the only reason we knew that is because the anaesthetist was able to give me information as I gave him information. So that's really important. I realised that I've been whittering on, so we're going to get on with it. We are getting towards the end. So damage control surgery is a staged procedure. We leave the abdomen open, we don't join the bowel, but the patient might need a definitive operation, and 1 operation is always going to be better than 2 operations. Is their physiology good? That's the information you'll get from the anaesthetist. Are the injuries relatively simple to fix? That is the information that you're going to convey to the team around you. If the patient's physiology is poor, or if the injuries are complex or extensive, then you're going to opt for a damage control approach. So that, to reiterate, that is prioritizing physiology over anatomy. A quick word on situational awareness and task focus. We get very, very caught up with saying we've got to maintain situational awareness, and it is absolutely vital. You've got to maintain time awareness. You've got to work out what's going on. But you are only one part of a team. I am a bloke, I can't multitask, okay? My wife tells me that all the time. If I'm doing a bowel anastomosis, if I'm doing a mobilization to get access to the inferior vena cava, I cannot simultaneously pay attention to how much blood the patient's getting, to what kit is being found, to who has gone off on a break, to all of those things that are important. So there are 2 things going on. So what is going on around you affects you, and you're affected by what's going on. So the approach that I try to take, I am not perfect, and I'm sure lots of people will be queuing up to tell you that I'm not perfect, is to brief the team. It's about communication. It's to say, right, I'm going to go and do a vascular repair. So I am not going to be able to answer questions for the next 10 minutes of this procedure. Everybody happy? Right. Get the kit? Right. We'll get started. And then when I finish what I'm doing, I come up for air and I'm regain my situational awareness. So I've been down 15 minutes doing whatever it is I'm doing. I come up and say, anaesthetist, how are we getting on? Scrub team, how are we getting on? I've been successful. I've not been successful. And those are really, really important concepts. So getting towards the end, where is my patient going? Most of these patients are going to intensive care, but if they've had a relatively simple operation, they've had a primary procedure, everything's hunky-dory, why can they not go back to the ward? Have they had a CT scan? Were they so ill they couldn't make it to CT? Do they need to go to CT? Are we going to take them to the interventional radiology suite after that? Do they need ongoing resuscitation to manage their physiological derangement? Are they cold? Are they coagulopathic? Are they ready for another lot of antibiotics? When are we going to take them back to theatre? Have they got packs left in? Have they got bowel incontinuity? What's the nutrition plan? So all of these need to be thought about, documented, and communicated to the team. And I'm a big fan of a face-to-face communication. I will admit it doesn't always happen. At 3 o'clock in the morning when I've been woken up, dragged in, done a laparotomy, the last thing you want to do is to be going around and having these conversations. But if anything, those are the times that it's most important, because we're all tired, we're all not functioning at our best, and the patient needs us to function at our best. So to summarize, the trauma laparotomy, as we've discussed, does have a cool soundtrack, although that soundtrack normally goes bleep, bleep, bleep of the anesthetic machine rather than something composed by John Williams. Trauma laparotomy involves a structured, reproducible approach that aids in reducing stress. It's not going to get rid of stress, it just helps. The injuries in the patient will tell you what surgical techniques to use. That is absolutely important. And just because it's trauma and just because you're there in shorts, t-shirt and flip-flops doesn't mean that as much of standard perioperative care practice is required. Okay, that's really, really important. So in conclusion, trauma is stressful. Surgeons are not always annoying idiots. Sometimes we just don't respond well to that level of stress. Not everyone thrives in that situation. It doesn't make us bad people. Sometimes we're bad people. And just occasionally, it doesn't matter whether you thrive or whether you don't thrive. If your patient needs you, you don't have the option of saying no, thank you. But no trauma I've ever done is as stressful as a child who swallowed an operation buzzer. So I leave you with that thought. Thank you so much to Anna. I'm sorry I'm running a little bit over time. And thank you so much to Trauma Care. And we agreed beforehand that I was going to now read down the questions and see if there's any that can be answered. And it's now popped up to the top. So Q&A, I've got one question. How often is a patient genuinely too unstable for CT and needs to go straight to theatre? So we do have some data on that, and of our code red patients, so that's the sickest, most unstable patients, it's something in the region of 10 to 20%. So that's probably, in my experience, 1 every 6 to 8 weeks or so for patients who are too unstable for CT. In our experience, they do badly, but then they're so sick they can't go to a CT scan, which is right next to resus. So they're always going to do badly. Do you also use suction as well as packing? Yes, suction is really important. You might have noticed in the video that they have 2 suckers. I do have 2 suckers going, and we use them all the time. And we sometimes use cell salvage, but actually in the beginning, you just need to get that blood out of the way. So I'm not going to suck all the blood out. I'm just going to get rid of it. And then the suction is to expose specific bleeding points for your definitive injury. How do you train your team for DCS, especially in the trauma unit where this is rare? That's a great question. I'll be honest, if I had an answer to that, I would commercialize it and retire. I try very hard to get us to train. I think mental preparation is good. I think a morning briefing is good, and I've tried both of those with my trauma team. I think it is difficult for busy, I know not all of you are NHS staff, but most of you are. I think it is very difficult for busy emergency NHS teams to take the time out of their day to do this sort of in situ training and cognitive preparation and things like that. So that is a work in progress. And in a trauma unit, to be honest, you've just got to try harder because you're not doing it as often. People say we're too busy to train, and then the argument goes, well, actually, you're probably too busy not to train. Any suggestions about trauma care reform from a systematic and educational approach? So my suggestion, which comes with a health warning saying that I have utterly failed in every possible way to achieve this in my NHS practice, but what I would like to see is us run team-based in situ trauma training weekly, probably ideally daily, but weekly. And every morning when you do your theatre brief, so those of you who work in theatres will know that we will do a team brief in the morning and a list brief and go through all the cases. So for the emergency theatre teams, that we have a 5 or 10 minute, what do we do for a damage control surgery, damage control laparotomy? Where's the kit? Who's going to do what? Think about it like that. And then watching videos, going to seminars, little simple things. It doesn't need to be fancy and expensive. How well does Cocker's maneuver work? It works if you're so Cocker's maneuver, you'll have to remind me if you mean Cocker's maneuver as in occluding the portal triad. If you are bleeding from the liver, it works perfectly, but you can only leave it on for 15 or 20 minutes. So it's, for me, as a non-HPB surgeon, it's great for, I'm calling in HPB help. And what would I do for aorta IVC injuries? So the last case that I did, the case where I made the iatrogenic small bowel injury, he had a common iliac vein through and through stab wound. So what did I do? Along with another consultant general surgery colleague, as well as a vascular, we called a vascular surgeon, but it pretty much solved the problem by the time the vascular surgeon turned up. We exposed the retroperitoneum by doing the appropriate visceral rotations, so left to right and right to left, got proximal and distal control exactly as we would for any elective procedure. And then what I did for the common iliac vein was to repair it. Now, the exact surgical, the technical details are probably beyond the scope of this, and I'm happy to talk about that in more detail, but there are some great videos on YouTube on how to do vascular repairs in trauma. And that's actually all the questions. Any more for any more?
Give them a couple of seconds, but just a reminder, everybody, that if you aren't a trauma care member, now someone in the chat did say if you're a free member, which I'm assuming is one of our academic partners. Yes, if you are a member through getting it complimentary, or if you're an academic partner, you still get free certificates. Do not worry. As long as you got that welcome email in your inbox saying, welcome to trauma care, you get a certificate. It doesn't matter how you became a member, you get a certificate. But if you are not a member, all you need to do is scan the QR code that's on your screen right now. It'll take you through to our feedback form. You fill that out, and as soon as that is filled out, you've got to fill it out fully. You can't just click on it and think you get a certificate. You go all the way through, and then we will send a certificate through to you tomorrow. So scan the QR code that's on your screen now if you're not a member of Trauma Care, and you can purchase a certificate for £1.99. And saying that, don't think there are any more questions that have come in, unless any have popped in the chat rather than the QA box. Oh, so it's a bit more of a personal question at the bottom there from Luke. I don't know if you want to reply to that privately, or
at what age? Okay, so I'll give this to everyone just as we finish up. So I know it sounds a bit geeky and a bit sad, but I knew that I wanted to be a trauma and emergency general surgeon when I was 14 years old. Now, I didn't know it was called that. I knew that I wanted to be the person who looked after the sickest patients in the hospital and who fixed them, which is very geeky. I will give a shout out to trauma care that having established that I wanted to be a military trauma surgeon, I went to a trauma care meeting probably about 15 years ago now. And I was very lucky at that time to meet the professor of military surgery, who gave me some very good advice and helped me out with getting onto an MSc in trauma science. And that sort of developed my academic side. So at what age did I start my surgical training? From the very beginning. I was a little bit older than some people because I'd done my military time, my time out in the fleet on board submarines prior to starting training. Depending on what level of ED doctor you are, there is absolutely no reason not to change tack and go into surgery. And if and when I rule the world, I will reinstigate having general surgeons and emergency general surgeons do emergency medicine, because I strongly support emergency general surgeons and trauma surgeons having a good understanding of the entire patient pathway from pre-hospital through emergency medicine, through theatre, all the way to ITU and the ward. And yes, for Malcolm Loudon, yes, it was Mark Midwinter who sorted me out in that respect. And
I mean,
Luke,
that's
if Luke wants to get in contact and get some more personal or deeper information, that's absolutely fine.
Perfect. Luke, if you want to message, if you do want to do that, just drop an email to admin@traumacare.org.uk and we'll get that all sorted for you. Thank you very much, Nick. And that's wonderful to hear that we helped you out in your path to becoming who you are today. So that's lovely to hear, which is another great point of really coming to the trauma care conferences, not just for the learning, but for the connections that you can make as well. Now, hopefully everyone's had enough time to get their QR code scanned. If you haven't managed to scan it, or you haven't got the ability to scan it, as some people don't, please do not fret. You can just email us. I've said it enough, but you can just email us at admin@traumacare.org.uk or myself at anna.hickling@traumacare.org.uk, and I'll send through that paid certificate link for you. I will also send out the usual email tomorrow with the link on it. Please do check your spam folders, as a lot of our emails are falling there at the moment due to the system upgrade. And with that said, all that is left to do is thank our wonderful sponsors for trauma care. So we've got plenty of sponsors and they are all as equally as wonderful and as amazing as each other. And hopefully if you scan the QR code that's on your screen now or go to the websites, you can learn more about the work that they do. First up, we have Penthrox and Galen. It's mainly Galen who, obviously, as we know, they create Penthrox, the first line emergency analgesic. If you want to learn more about what they do, go to www.penthrox.co.uk/usage. You can get some Penthrox training on that website or scan the QR code that's on your screen there. This is the sort of the T's and C's and lots of words that I don't personally understand, but hopefully if you need a read of it, because I'm sure you do, I can get that sent across to you. And proudly sponsored by Icarus. You've probably seen recently, I think it was 2 weekends ago, they had their start course. But if you scan the QR code that's on your screen now, it will take you through to that page. And there is another one coming up in May as well. So their start course is on in May. It's like a virtual headset, virtual reality, really immersive training course. They've got loads going on. Or just go to www.icarus.com to find out more about all the training courses that they have coming up and around the country and indeed the world. And proudly sponsored by CallSafe. CallSafe came on board this week, finally, as our full sponsor, and I'm sure Toby, if he's in the audience tonight, is very happy for me shouting that out. They are finally on board as one of our sponsors. They are our lovely first aid sponsors. They do amazing work up and down the country. We've got loads of things in the pipeline with these guys. You can also catch all of these sponsors at the Manchester conference if you do want to find out more, or scan the QR code that's on your screen now if you won't be there. And World Extreme Medicine, these guys do amazing work all over war-torn and countries that are sort of dealing with austere environments at the moment. They do absolutely incredible work. It's really worth checking these guys out. So scan the QR code that's on your screen there. If you don't want to know more about what they do, but you want to learn more about the training courses they have available, that QR code will take you through to that as well. And we are also proudly partnered with Pro Trainers UK, the University of Sunderland, the University of Wolverhampton, and as of yesterday, which is why they're not on here, so I am very, very sorry, Mike, but we are also partnered now with the University of Gloucestershire as well. Our wonderful partners over at Pro Trainings provide us with the commercial side of things, and our academic partners in the University of Sunderland, Wolverhampton and Gloucestershire. We're very, very proud to be working with these guys and providing them with free webinars, free learning resources, and hopefully coming up soon, some free conferences as well. So that is all there is to say from myself. Thank you so much, everybody, for joining us for what is going to be my last Wednesday webinar in some time. But more importantly, thank you, Nick, for talking to us tonight on such a, in a bizarre way, I'm not sure if it's right, but a charismatic and really, really helpful webinar. You've done a fantastic job for your first time. You had nothing to worry about. Everyone thoroughly enjoyed it, and it was a wonderful talk, and I can't wait for the wider world to see it when I get it online. So thank you very much, everybody, for joining us wherever you are in the world. I know we've had people join us from the USA. As you can tell, the light has gone down in this room since we started tonight. From the USA, Wales, just down the road from where I live, down in Preston as well. It's lovely to see you all, and some familiar names in there as well. Wherever you are and whatever you're doing, enjoy the rest of your time. Be nice to yourself, and we shall see you later on. Thank you very much, all, and thank you again, Nick.
Bye-bye. Thank you very much.